respected senior professionals, on injectable semaglutide, that is the Ozempic, once in a week. So in the next few minutes, I will talk on unveiling the clinical power of the Ozempic in the type 2 diabetes management. So the three agendas, the first agenda will be the semaglutide, the global blockbuster, followed by cardio, kidney, metabolic care continuum, and what about the smart and the convenient solution with the Ozempic in the management of the type 2 diabetes. See, the management of the type 2 diabetes is multi-dimensional. So for type 1 diabetes, we have the only one answer, that is the insulin for lifelong. Whereas for the type 2 diabetes, we treat with the dietary approach, exercise, yoga, meditation. So these are all the non-pharmacological management, followed by the pharmacological management with a lot of the OHS in our hand, like metformin or sulfonylureas or the pioglitazone or voglibose or the gliptins and SGLT inhibitors. And finally, most of the people, they also require a basal insulin or intensification of the insulin at a later time. But earlier, we all thought that metformin is the first line of the management in all the type 2 diabetes unless otherwise contraindicated. We use it to start with the metformin, and after the metformin we use it to write add the different combinations depending on the HbA1c, depending on the fasting hyperglycemia, depending on the postprandial hyperglycemia. But nowadays, the first line therapy is individualized. So whatever the drug, whatever the OHA families are there, you can choose any one of these OHAs as the first line of the therapy, provided if the person requires these drugs. So for example, a obese individual, so I think the first line of the therapy would be a semaglutide or the metformin. Suppose the person is a lean type 2 diabetes, so your first line management could be your sulfonylureas. Suppose only the postprandial hyperglycemia, so then the first line management could be the voglibose, so likewise. So when you choose a single drug as the first line of the therapy, it should be proven efficacy and safety with the high level of the evidence. Benefits outweigh the risk. So all these drugs will have the few side effects. For example, sulfonylureas, excellent drugs to reduce the blood sugars, but at the cost of the hypoglycemia and weight gain. Pioglitazone, excellent drug to tackle your insulin resistance, but at the cost of your weight gain or your osteoporosis or malignancy of the bladder in some cases. In the same way, if you see the SGLT inhibitors, they are very, very useful drugs, but at the same time, the incidence of the monilial infections or incidence of the urinary tract infections are very high. So whenever you want to choose a drug, the benefit should outweigh the risk. Effective in the majority of the target population. So whenever you prescribe any drug, that should be given for a majority of the population and whatever the positive effects in those individuals. Patient convenience is very, very important. So that is the reason almost all the OD drugs, they favor the people's favorite drugs are always the OD preparations or once in a week preparations. Provides the good value for the money. So that is also very important, especially in a country like India, and recommended by the guidelines. So any drug which is recommended by the so many guidelines, like our Indian guidelines or Canadian guidelines or the American guidelines, so probably, so that would be the one of the best medications to be prescribed for your population. So what makes this semaglutide the optimal first line therapy in the type 2 diabetes? As I told you earlier that the type 2 diabetes, the first line therapy is almost individualized. So whenever you see a fellow with a overweight or the obese, with a high cardiovascular risk or very high chronic kidney disease risk, so obviously we have to choose one of the few molecules only, and one of these molecules is the injectable semaglutide. It's a very powerful glucose reduction as far as your HbA1c is concerned, and there is an added advantage of the weight loss. So for a optimum weight loss, I think the semaglutide works better when compared to the other drugs. And most important is the cardiorenal protection. So whenever you see a diabetic individual, now the definition of diabetes has changed. So earlier diabetes means your beta cell failure or your pancreatic disease or a metabolic disease. Now the definition of diabetes means metabolic and vascular disease. So for all the metabolic diseases or for all the people with diabetes, we also need a vascular protection. So vascular protection means not only your heart, but also to your brain and also the peripheral vessels. So these drugs, the semaglutide, is an excellent drug to give you a cardiorenal protection. And of course, the dosing convenience is very, very useful. So these drugs are available only once in a week. So obviously, the convenience will be very good and the compliance also will be very good. So this is the weight compared to the other drugs. So whenever you use one drug, usually we'll compare with what are all the common drugs so far we would use. Suppose if you want to use one antibiotic, a new antibiotic. So obviously we'll compare with your amoxicillin, or you compare with your ceftriaxone, or you compare with your ciprofloxacin, etc. So in the same way in the OHS, you compare the semaglutide with your SGLT inhibitors, DP4 inhibitors and the metformin. So if you see the glucose lowering efficacy, so the semaglutide 3 plus, SGLT inhibitor 2 plus, DP4 inhibitor 1 plus and metformin 1 plus. So any wrong in this slide? As far as the glucose lowering efficacy is concerned? So are you say okay for all these glucose lowering efficacy? See, for any drug, so the drug is very effective on terms of your HbA1c reduction. So what are the two molecules which gives you the highest HbA1c reduction? They are metformin and sulfonylureas. So the metformin reduces HbA1c to the tune of about 1.5 to 2%. In the same way, your sulfonylureas, they also reduce the HbA1c to the tune of 1.5 to 2%. So these two drugs reduces the glucose very well. So glucose lowering efficacy is semaglutide 3 plus, and you also should give the metformin also maybe 2 plus or the 3 plus. Yeah. So if you see the DP4 inhibitors, so when compared to these drugs, so obviously much lesser, and SGLT inhibitors is the most peripheral acting drug which acts only on the kidneys. So obviously the HbA1c reduction to the tune of about 0.8 to 2%, 1.2%. Effect on the body weight. See the semaglutide, good. Maximum weight loss is seen with the semaglutide. SGLT inhibitors also we see the good amount of the weight loss, maybe 4 to 5 kgs or the 6 kgs. But in some cases, even though they say negative for the metformin, so in our personal experience, the metformin also loses the body weight in some individuals. Sometimes, the simple metformin therapy also they lose body weight in some individuals. But of course, the semaglutide is the highest weight loss will be possible with this. And CV risk factor reduction. So as I told you that only the two drugs among all the OHS are the cardioprotective drugs. What are they? One is the GLP-1 receptor agonist and the second one is the SGLT2 inhibitors. These two are the cardioprotective drugs. So that is the reason those people who are obese, those people who are smokers, those people who are having the strong family history of premature atherosclerosis, obviously you have to use one of these two drugs or both the drugs. In most of these individuals, those two drugs are either semaglutide and SGLT inhibitors or both. Pleiotropic benefits. So these drugs also have a pleiotropic effects, extra glycemic effects, like your platelet functions, maybe antioxidant functions, and maybe anti-atherosclerotic function, maybe reducing your endothelial dysfunction. So all these benefits will be seen with these semaglutide and SGLT inhibitors. That is the reason they are more cardioprotective and the renoprotective. And risk of hypoglycemia, all these four drugs will be low. So the only two drugs which have the highest value of the hypoglycemia, one is the sulfonylureas as far as the OHS is concerned, and the second one obviously most potent hypoglycemic agent is the insulin. So insulin and the sulfonylureas, they cause more of hypoglycemia when compared to the semaglutide, SGLT inhibitors, DP4, they are all very, very low risk of the hypoglycemia unless you combine with the insulin, unless you combine with the sulfonylureas. So these are the good lowering efficacy, body weight loss and CV risk factors benefits, pleiotropic benefits, and hypoglycemia risk is very, very low with the semaglutides. So you have the two drugs, one is the oral and Rybelsus. We start with the 3 milligrams and then we upgrade it to the 7 milligrams and then we upgrade it to the 14 milligrams. That is every day one tablet has to be taken on the morning time and empty stomach, etc. But now we have the injectable semaglutide, that is Ozempic, is available in 0.25 and the 5 and then the 1 mg once in a week. So this is the power of the semaglutide, the oral convenience. So these are all the drugs here away. And Rybelsus, up to the 2.6% HbA1c reduction provided. If the index HbA1c is very high, obviously you also achieve highest HbA1c reduction. For example, at the time of the initiation of your therapy, if the HbA1c is 14%, 13%, 12%, that is very often seen in our clinical practice. In those individuals, the HbA1c reduction is very high. On the other hand, if you start at 8 or the 9 HbA1c, maybe the HbA1c reduction may be 1 or 1.5 or the 2%. So this is approved by the US FDA, the Rybelsus. This trial is a sole trial. So nearly the 9,000 odd individuals, and fortunately Indians are also included. Earlier, in all these international studies, Indians were not included. But of late, last 1 decade, so whenever a new drug has come entered into the market, into the diabetes arena, so obviously the Indians are also included in those group. So the primary prevention, you all know what you mean by the primary prevention. So getting the first cardiovascular disease. Maybe first myocardial infarction or CVA or peripheral vascular disease. What is secondary prevention? already had a cardiovascular disease, and now the recurrence of the cardiovascular disease, prevention is a secondary prevention. For both the primary and as well as secondary prevention, so these drugs can be used because of their reduction in your blood sugars, reduction in the body weight, and reduction in your pleiotropic effects. So it's a global blockbuster, Ozempic. So 7 million people are taking this. This is the up to the 2025 May data. I think by this time maybe the 9 million individuals, and 75 countries approved and the launch, and the #1 prescribed drug as far as the GLP-1 receptor agonist is concerned. Now it is also very much available in India. So what about the cardio, kidney and metabolic care? So as I told you that now the diabetes means metabolic and vascular disease. So this is the one. Diabetes is not an isolated disease. It's a big syndrome. So diabetes means vascular inflammation. So that is the reason in all the diabetic individuals, high risk individuals, we get the high sensitivity CRP at least once in 6 months or once in a year. So the normal is less than the 1 to 3 is the medium risk, and more than 3 is the very high risk. So those people with a high HV, high sensitive CRP, so obviously you can expect the cardiovascular events in the near future, and treat with the dietary approach, treat with the semaglutide, treat with the SGLT inhibitors, and also treat with the vascular protective drugs like your aspirin or clopidogrel, and the high intensity statins, maybe rosuvastatin 20 or 40 milligrams. Weight gain, yes, even 1 kg weight gain will give you a lot of the side effects as far as the diabetes is concerned. So more the weight gain, more the blood sugar, more the blood pressure, and then the more the circumferential, more the adiposity, and more the atherosclerosis, etc. Hypertension is a very close friend of the diabetes, a deadly duo. So in all the diabetic individuals, you should keep the blood pressure as close to the normal as possible. So the normal blood pressure is 120/80. So in all the diabetics, it's very easy to say that your target is 120/80, but it is very difficult to reach that stage of 120/80 in all the diabetic individuals. So at least 130/85, not more than 140/90 should be your target of the blood pressure in all the diabetic individuals. You have to use the ACE or ARBs as the initial agents, then you can add the calcium channel blockers or the diuretics like chlorothalidone or hydrochlorothiazide, and after that you can use the alpha blockers like your Minipress XL or Prozopres XL, and finally you can also use the loop diuretics and also the Arcamin central acting drugs, etc. Adiposity is a big risk factor for the Indians. For a given BMI, we are having the more fat cells, so the weight circumference is very important. You should be less than the 90 centimeters in the males and less than 80 centimeters in the females. Insulin resistance is a very, very high in our Indian individuals. So insulin resistance is the root cause for all the diseases of the metabolic diseases. If you are going to get the diabetes, it is because of the insulin resistance. If you are going to get the hypertension, it is again because of the insulin resistance. You are getting the dyslipidemia, it is because of your insulin resistance. And if you are getting the fatty liver, again it is because of the insulin resistance. So insulin resistance is a very, very important ingredient to cause the metabolic syndrome nowadays. So these are all the important risk factors for the end organ damage. We have to protect these organs in all our diabetic individuals. Weight further complicates the matter in type 2 diabetes. 7 times increased risk of the mortality in people with diabetes who have obesity or the weight issues. So this is the importance of the weight loss in all the diabetic individuals. You all know that normal BMI 23, but no one is here with the BMI 23, maybe 1 or 2 fellows. Okay, all our BMI is more than 23, 24, 25. My BMI is 26.5. So imagine. So we have to reduce the BMI in our individuals, otherwise we are at risk of getting the metabolic diseases. Weight loss. It is very easy to say weight loss. So weight loss because of your dietary approach and your exercise, and then you have your semaglutides, etc. It reduces the pathophysiology of the several diseases, reverses or slows down the disease. But this is a very important of. So when you lose the weight loss, maybe 10%, maybe 20% of the weight loss, so there is a reversal of the diabetes is also possible. Even if you lose the 5% of the index weight loss, you will get nearly 10 to 25% of the benefits. If you lose the 10% of the index weight loss, you will have about 25% of the benefits. If you lose 20% of the index weight loss, so obviously you can reverse the diabetes, you can reverse the hypertension, you can reverse the fatty liver. So all these metabolic consequences can be reduced to a zero level with your excellent weight loss. So it is very easy to say, again, very, very difficult unless you have the behavioral therapy. So you have to adjust your hypothalamus, your satiety center to such a level that you should eat less, work more. promotes the glycemic control, weight loss, and impacts the cardiometabolic risk factors. So it prevents both micro and macrovascular complications. So micro means your nephropathy, neuropathy, and retinopathy, and macro means your cardiovascular disease, cerebrovascular disease, and peripheral vascular disease. Not only these complications, even your complications of the diabetes, like your infections, that also will be reduced with the weight. Not only the infections, oncology, malignancies also will be reduced with the weight loss in a diabetic individual. So diabetes and more weight or obesity means more of gastrointestinal malignancies, your lung malignancy, thyroid malignancy, in females uterine malignancy or ovarian malignancy, breast malignancy. These are all very, very common in obese and diabetic individuals. So GLP-1 receptor empowering the comprehensive patient well-being. You are all familiar with this slide. I have shown you only 7. If you add another one, so that is the omnious octet. So these are the 8 ways of getting the hyperglycemia in our Indian population. So omnious octet. So 8 ways of getting the hyperglycemia. So one is the beta cells. So once the insulin function is reduced, you will get the hyperglycemia. And the liver, when there is an increased hepatic glucose production, you will have the hyperglycemia. And adipocytes, when you have the lipolysis, so neoglucogenesis, and you will have the hyperglycemia. And impaired appetite regulation in the appetite center, binge eating and continuous eating and more eating, etc. So definitely will lead to more and more hyperglycemia. And then the alpha cells, they secrete the glucagon, they are antagonists to the insulin. So obviously glucagon, hyperglucagonemia, so hyperglycemia because of the increased glucose output. And intestines in the 2 ways. One is your absorption of your carbohydrates, and the second one is your incretin hormones. 2 incretin hormones are there, GLP-1 and the GIP. So these 2 will be impaired in the presence of the hyperglycemia. So in all the diabetic individuals, the incretins are at lower level and decreased glucose uptake in the muscles because of the insulin resistance. So these are the ways, and of course the 5th one is your kidneys. So the poor handling of the glucose. So glucose is reabsorbed, filtered, and again reabsorbed, and you prevent the reabsorption by using the SGLT inhibitors, so you can have good first. So this drug, the particular Ozempic drug, will act on the 7 ways of your hyperglycemia. All these ways, these drugs will work. So that is the reason, if you add the SGLT inhibitors to this drug Ozempic, and you are controlling 100% of the ways of getting the hyperglycemia. So a wide range of the benefits for our patients: weight loss, yes; glycemic control, yes; primary prevention is yes; and MACE outcomes, yes; major adverse cardiovascular events outcomes also reduced by 26%. Heart failure, again it's a very big disease nowadays because of the aging population. More and more hypertensives, more and more diabetes, more and more IHD, more and more post-PTCA, post-CABG. A lot of the people will have the heart failure. So the biomarker for the heart failure is your NT-proBNP. So that will be very much elevated. So obviously you have to use these drugs. Peripheral arterial diseases prevention. So the fatty liver and all-cause mortality. So all these benefits will be seen with this semaglutide. So it is a human GLP-1 receptor analog. It exhibits 94% homology. Half-life is of 7 days. That is the reason once in a week, and extensively studied. So I have the several comparisons. So how it acts versus your SGLT inhibitor, versus insulin, D4 inhibitors, and other GLP-1 receptor agonists like exenatide, liraglutide, duraglutide. They are also available in the market. But now the 90% of the share of this GLP-1 receptor agonists goes in favor of semaglutide. So the Ozempic reduces the A1C by 2.8%. That depends on your index HbA1c in people with high baseline A1C levels. So with weight loss, not only your reduction in your blood sugars, but also weight loss, CV benefits, and kidney benefits. So 8 kgs weight loss. So 2 out of the 3 achieved the clinically meaningful weight loss and reduced waist circumference. This is also very important. So more than the BMI for Indians, waist circumference is more important. So Wegovy is the brand name. So maximum dose is 2.4 milligrams. So we start with 0.25, then the 0.5, then the 1, and then 1.7 and 2.4. So there is 18% weight loss, and 1 out of the 3 achieved 20% of the weight loss. This is the very important. See, achieving more than 20% of the weight loss, that is the very, very important in those people who are obese, whose BMI is more than 27, or whose BMI is more than 30 or 35. So we are seeing a lot of the people more than 110 kgs, 120 kgs, 130 kgs. So in those individuals, don't be happy with just 5% or 10% of the weight loss. You require 25% or 30% of the weight loss. That is possible with these drugs. And of course, if the person is morbidly obese, I think the bariatric surgery is the only rule for them but now after the introduction of these drugs, the bariatric surgery is at a lower seat, at the back seat for majority of our obese individuals. It is endorsed by the American Diabetic Association, very high efficacy drug for both glucose lowering and also the weight lowering effects. Cardiorenal data. Sustain 6 is a cardiovascular outcome trial followed by the FLOW, that is a kidney outcome trial. So this cardiometabolic trial shows 12% reduction in your free fatty acids, 14% reduction in your triglycerides, 12% reduction in your VLDC, and 8% reduction in your LDL-C cholesterol. So out of them, the most worst cholesterol is the LDL-C cholesterol. So that has to be reduced. So earlier our goal of the LDL cholesterol is 100 or 130 or 160 earlier. Now it is above almost like 55. So in most of our diabetics, you have to keep the LDL at 55. Suppose the post-CABG or post-PTCA, even 30 is your goal of the LDL-C. It is very easy to say, but very, very difficult to achieve that LDL goal of 30 or 55, even with the 40 milligrams of the rosuvastatin or 80 milligrams of the atorvastatin, though you have to use the combination of these drugs. So statins plus bambodoic acid or statins plus ezetimibe, or some people you have to give the injectable monoclonal antibodies like CPK inhibitors also. So now coming to the renal flow, renal studies, the kidney outcome trial is the flow. So this trial shows UACR. This is a very important investigation to be done in most of our diabetic individuals. So please get the UACR, that is urinary albumin creatinine ratio. It should be less than the 30, that is the normal. If it is 30 to 300 is the microalbuminuria, more than the 300 macroalbuminuria, more than the 500 proteinuria. You need not remember these figures, but one thing is very clear that elevated urinary albumin creatinine ratio is at risk of getting the CKD in the near future. So now UACR or urinary albumin creatinine ratio no more a risk factor for your nephropathy, damaging your kidneys, but also damaging the vessels. So the albuminuria, more albuminuria means more vascular diseases. So that is the reason all these kidney patients, they die in the hands of the cardiologist rather than the nephrologist. So 65% slower use of the kidney function and proven to delay the kidney failure by up to 5 years. That is a very, very important point. If you delay the renal failure, if you keep the A1C, creatinine at 1.5 or 1.5 or 2 or 2.5 for 3 years, 4 years, 5 years, you are giving a lot of the benefit to the patient. Otherwise, the progression of the kidney disease is very fast in some individuals where they may need the dialysis or the transplantation in the next 2 to 3 years. So the Ozempic is the smart one, is a very convenient one. As I told you that 0.25 milligrams once in a week. In the next month, so step up to 0.5, and the third month step up to the 1. So if the patient still you are not happy with the weight loss, so that means if you want to get the 20% weight loss or 15% weight loss, then you can upstate to 1.7 and the 2.4 also. So this Ozempic has a long legacy of the use. A glycemic management is good because it reduces HbA1c to the maximum. Weight management is good, so you can reduce up to the 20%, 15 to 20% is possible. And the CVD risk reduction is very good, and CKD risk reduction is also very good. So it is a very convenient once in a week, so used by so many millions of the population. So I think the next slide is the best slide. Ozempic position itself as an ideal first line agent for the type 2 diabetes management for majority of the patients in the practice. So thank you very much for your patience here.